Welcome, everyone. Thanks for joining us tonight. My name is Alan Baggett. I'm an internal medicine physician here in North Alabama, an assistant professor at UAB's Huntsville Regional Medical Campus. And I'm joined tonight with Dr. John Fanning, who is the Regional Department Chair of Internal Medicine at the Huntsville Regional Medical Campus of UAB, and is going to be sharing with us some thoughts about telemedicine tonight. John, thanks for being here.
Sure. Thanks, Alan. Thanks for having me.
Absolutely. I appreciate you sharing your insights. I understand that your internal medicine clinic here at Huntsville has made a transition to telehealth for a large majority of the patients that we're taking care of. I just wanted to get your insight and what you've learned since making that transition.
Well, so of course, COVID kind of forced everybody to change the way that they're doing ambulatory medicine, trying to avoid bringing patients into the office to avoid contact. And so we started a couple of 3 weeks ago trying to dip our toe and trying it. We're currently using UpDocs, which is a program that lets you connect with a patient through their smartphone or computer. And it's actually been a pretty smooth transition that we've gotten the patients been able to connect pretty easily with us, and they've enjoyed it. I think the fact that they're able to see the physicians face to face has been a real benefit for them. The residents have learned how to do it. They picked up on it a lot quicker than old people like me, but they're learning how to use it, how to interact with the patients. I think it's been a pretty successful launch.
Wonderful. I know initially with this transition, a lot of internists, primary care physicians out in the community were very concerned about billing. And I understand there's some differences between what Medicare is reimbursing versus Blue Cross Blue Shield. Can you kind of fill us in on what the status is of that?
Sure. Well, my understanding is, Medicare, CMS made the decision to release the waiver to allow us to do telemedicine that previously was only allowed in rural areas. And they took that away. So they took that waiver or replaced that waiver to allow us to be able to use it. The stipulation is you do have to do an audio visual where you actually see the patient on camera in order for you to bill for the standard 213, 214 billing. Blue Cross only goes to 213, but they do allow you to do it over the phone. And Medicare does have telephone only codes, which are paid at a lower rate. So it is still possible to communicate with the patient and have billing using the telephone only. We're trying to do mostly with the audio visual, not only for the billing purposes, but also I think like I said, we talked about the patient really enjoying being able to see the provider face to face. I think it gives them some comfort.
Sure. This has sort of been forced upon us in a sense because we're trying to manage public health and limiting the number of exposures of COVID-19 in our clinic and in our environment. And in so doing, it creates a little bit of a challenge, it would seem, on the front end. So my question is, how are you triaging? What are your nursing staff, front desk workers doing to assist you? And what decisions are you making to triage patients to telemedicine versus coming into the clinic?
So a lot of times they'll run it past me if it's a patient who's having an issue. I mean, it's just like we would normally do if a patient is having chest pain, abdominal pain, things where you feel like you need to put your hands on that patient. We try to get them to come in, recognizing that there is some risk. If it's something that we feel like we can take care of over the phone or over the video, we're trying to encourage patients not to come in. There are some things that you can't do over the phone. We're also trying to avoid bringing in people who are at a high risk for COVID, older folks, trying to bring in folks, they're immunocompromised, trying to avoid bringing those people into the clinic. So it is a triage based on all of those things and an interaction between the nurses, the front office staff, and myself and the residents. If we really feel like the patient needs to be seen, then we bring them in. But because the volumes in the clinic are lower, I think the relative risk of exposure is lower as a result of the fewer people in the clinic itself.
Sure. How is your diagnostic capacity? Has it changed at all, given that you're doing a lot more evaluation through a screen?
Well, I tell you the story about the lady that I saw that came in or called me with a sore foot, sore toe. I was able to make the diagnosis of gout over the phone, which is the first time I've ever done that before. I asked her if it hurt when the sheets ran across it, and she showed me her foot on the video, and I was able to see that her great toe was swollen and red, and she was able to palpate it for me and say that's where it hurts. And so the first time I've ever diagnosed gout over video.
Yeah, this is kind of a unique time and situation. Well, let me ask this, because I'm sure there's other internists out in the community right now that have no experience with telehealth. They understand the public health concerns with having a wide open clinic. They're taking some precautions, but perhaps they haven't leaped out into the telehealth sphere. What are some of the hurdles that you faced in initiating this process? And what are some of the things that you've learned? What are some tips and tricks for those who are considering this?
We first started using Zoom, which is the program that we're teleconferencing on now. That's a good program. It works well for people who are technically savvy. I think especially for the older folks that maybe aren't as technically savvy, it required a download of an app. And we actually had our IT department calling people ahead of time. Since we've switched over to this, to UpDocs, and I know DoxyMe is another one that's available. It's pretty simple. It uses the smartphone technology. They get a text message. They click on the text message link, and it connects them immediately to the system. And so it's actually pretty slick from that standpoint. Obviously, the limitation on the side of the patient, if they don't have a smartphone or a computer that allows them to connect, that limits them, and we would have to do that as an audio only. But the vast majority of people either have a smartphone or have a relative with a smartphone. I spoke with a family member today of a patient who didn't have a smartphone, and that's how we were able to communicate. So I think from that side, the technology is much easier if you can use the smartphone technology. I think it's the biggest leap is just getting people to be convinced that they want to connect with us via the audio visual. And I think the people that once they do it, understand it, I think it's worked out pretty well.
Excellent. Wonderful to hear. Again, given that things are changing around us and we're somewhat being forced into a different paradigm of how we take care of patients on a daily basis, after all this is said and done and we have learned some new tricks, do you see telehealth, telemedicine becoming more prominent in the primary care office, and in what roles?
I think the fact that we're forced to learn how to do it, I think we're going to learn to be better at it. I do believe it has a place beyond this. For example, a patient who is bedbound or is homebound and unable to really get out of the home, maybe that has transportation issues. I can see this being an opportunity where we could have visits with them, face-to-face requirements for Medicare for DME, I think would be a good option for that. The patient wouldn't have to come in. Be seen. And it was initially designed for the rural areas. If a patient lives 30 miles away, but they have no transportation, they might as well be 200 miles away. So I think there are some options and opportunities there that if CMS would be willing to allow us to do that, I can see it being used in the future.
Awesome. John, thank you so much for your time, sharing these valuable insights in telehealth and telemedicine with us. We very much appreciate you joining us tonight.
Sure, no problem. And you have a good evening. Take care.
Have a great evening. For those that are following along, thanks for watching tonight. I'm highly anticipating more videos from Alabama's ACP chapter in the upcoming days and weeks as we go through this pandemic. If you've felt like this video has earned your interest, please click the like button, comment, or subscribe to our channel. And additionally, be sure to follow us on Facebook and Twitter so that you can get some up-to-date information on a daily basis. Look forward to seeing you next time. Thanks, John.
Yeah, take care.
Bye.